There are no other questions. We'll go on to the next talk by Dr. Sam, who's presenting on FM5.
Good morning, everyone. Presenting on behalf of Medicine 5. Presenting Mr. M is a 23-year-old intellectually disabled male who came from Tirupur with complaints of lethargy for 1 month in the form of excessive sleepiness, unquantifiable weight gain for the past 1 month with reduced appetite, slowness of speech, and slowness of his daily activities over the past 1 month. So Mr. M is born as second son of non-consanguineously married parents. When we look at the antenatal history, it was uneventful except for a postdated pregnancy, which was recalled by his mother. And he was delivered at home, and he did not cry soon after the birth. And the postnatal period, he had delayed development of milestones. As far as the mother recalls, his neck holding was attained at 8 months instead of 2 months. And he sat with support at 8 months and was not able to crawl or creep or stand with support by 10 months. And overall, there was a global developmental delay in all domains, fine motor, gross motor, social, as well as language. So his mother sought medical attention only at 6 years of the child's age. And at 6 years of age, he was evaluated and found to have hypothyroidism. However, there is no family history of any thyroid disease. There is no history of developmental delay among his siblings. And there is no history of any teratogenic drug intake in the mother during her antenatal period. On examination, he was dull-looking, conscious, afebrile, with a dry, coarse skin. Pulse rate was 60. Other parameters were normal. So a 24-year-old male was diagnosed with congenital hypothyroidism with intellectual disability, now presenting with a 1 month history of weight gain, letharginess, and increased sleepiness and slowness of activities. The differentials we considered were there is severe hypothyroidism, either due to poor adherence to therapy or any intestinal malabsorption hampering the drug absorption, or any maldigestion related to hypochlorhydria or increased metabolism of thyroxine. So we went ahead with the basic investigations. So he had macrocytosis with MC of 101.2 femtoliters. Otherwise, his electrolytes were normal. He had a borderline vitamin B12 level of 230. And we sent a TSH level, and it came out to be more than 750 micro international units per ml. And his FTC was 0.83 nanogram percentage. So it's a case of congenital hypothyroidism. So when we look at the prevalence of congenital hypothyroidism, it was 1 in 2,000 to 4,000 newborns. It may be a transient or permanent. So the causes include the most common cause, thyroid gland dysgenesis, which accounts for 65%, and inborn errors of thyroid hormone synthesis, which accounts for 30%, and TSH receptor antibody mediated, which is 5%. And there are certain mutations that can cause congenital hypothyroidism. So the mutations causing central hypothyroidism, certain mutations cause central hypothyroidism because of abnormal hypothalamic pituitary development or loss of specific components of hormonal pathway. That mutations can also cause abnormal thyroid gland development or dysgenesis. They can also cause abnormal thyroid hormone synthesis. So these are a whole list of mutations that are associated. Some may cause central hypothyroidism, and some thyroid dysgenesis, and some causes thyroid dysharmonogenesis. So the most common clinical manifestations include a prolonged jaundice, a problem with the feeding, hypotonia, macroglossia, delayed bone maturation, and umbilical hernia are also reported. So our case is basically the treatment refractory hypothyroidism. So when levothyroxine requirement is exceeding 2.5 microgram per kg daily instead of the 1.6 microgram per kg, treatment refractory hypothyroidism is considered a possibility. So if we look at the causes of this treatment refractory hypothyroidism, the most common cause is poor adherence to drug therapy, which we could make out from the patient's report and the history. Other causes include maldigestion related to hypochlorhydria. Example, patients who are on proton pump inhibitor therapy or other autoimmune atrophic gastritis, GI infection with Helicobacter pylori, etc. It can also happen with in cases of intestinal malabsorption, out of which it could be a luminal factor or intramural factor like short bowel syndrome, inflammatory bowel disease, etc. And other causes include the increased need which happens in pregnancy, and other factors down the line are Addison's disease, TSH heterophile antibodies, etc. So these are the substances that affect the thyroid function in patients who are on thyroxine. So these substances interfere with the absorption of thyroxine, like iron, calcium, aluminum hydroxide, etc. That's why we advise, and especially the antenatal mothers, to not to take iron and calcium tablets along with thyroxine in the morning. And increased hepatic metabolism by phenobarbital, phenytoin, carbamazepine, rifampin, etc. can also hamper. So for levothyroxine, we have conventional and novel drug delivery formulations like inhalers, soft gel capsule, solution, tablets, and also injections. Suppository form is also available. So we look at the role of intravenous thyroxine. So actually intravenous thyroxine is the first line of option for myxedema coma, but it can also be used in patients who are refusing oral administration, in people who have underwent subtotal ileal resection and intractable hypothyroidism treated with high oral dose of thyroxine. So the appropriate IV equivalent dose from the literature is 48% to 74% of the previously adequate oral thyroxine dose. However, this IV thyroxine is not recommended for long-term treatment due to the effect on thyroid hormone homeostasis. It can augment the calorogenic effect of norepinephrine and has direct effects on myocardium, sometimes also causing sudden cardiac death. So recommendation is a 3 to 5 days of IV levothyroxine is what is recommended. This is one of the case reports of a case of refractory hypothyroidism. She's an antenatal mother, and post-delivery, she was found to have elevated TSH levels of 651, and her oral thyroxine doses increased up to 400 mics despite her levels were high. And they were started on injection levothyroxine 200 microgram once in 3 days. And here, if you look at, there was a drastic fall in the TSH level of 68, and following another 5 more doses, her levels reached 28 micro international units per ml. So our case is a case of refractory hypothyroidism, possibly due to a malabsorption because he had a borderline B12 levels, and with a very high TSH levels of more than 700. So we administered him IV levothyroxine 150 microgram for 5 days. It's available in our pharmacy in a reconstituted form. So the learning point from this case is the treatment of refractory hypothyroidism and the use of intravenous thyroxine.
Thank you, Sam. Any questions or comments from the audience? Why did the patient take so long to get treatment, or only diagnosed at 6 years?
Yes.
After that, patient was on treatment or was not on?
Was on treatment.
What was the dose he was getting?
100 micrograms.
Yeah, but that does not fit into your. What is the weight?
Weight would be 60, around 50 kgs.
50 kgs. Okay, so 2 microgram per kg is what he was taking.
Yes.
And you said that he had some malabsorption or maldigestion. What is it? Did you work up like?
So
why he had this thing.
B12 levels were borderline low and pernicious screen, other things are awaited. We had sent
So
about-
you're planning a workup for this.
Yes.
Okay. But here you said compliance is also poor, right?
Yeah, compliance last 1 month. Compliance is also.
So I would say it's probably the compliance, and he was not on a higher dose. First, you have to ensure that compliance is adequate, and then. But here, this seems like a preventable cause, which was kind of missed, and probably for so long he was not taking it so properly. Perhaps. So, thank you. So next we'll have medicine 3, presentation by Dr. Akhil, Conned by the Cop.